Our advice to physicians is that recommendations regarding immediate antiepileptic drug therapy after a first seizure should be individualized, and they should be weighed based on the risk for a recurrent seizure, and that should be weighed against the risk of side effects from antiepileptic medication. And we found that those side effects are in the range of 7 to 31% for immediate therapy. However, the good news is that most of those side effects are mild and reversible. So if you lower the antiepileptic medications or change to another antiepileptic medication, you basically correct those problems. So the American Academy of Neurology has, I think, in their wisdom, developed and provides a number of tools to educate patients about this problem so that the patient can be a participant in this process and help the physician know what their preferences are, because we think it's a good practice and a best practice to involve the informed and educated patient in this process, because the decisions, as I said, are not black and white. I think what you do, the way you overcome that is I think you educate patients and see what's important to them. And patients differ. I have patients who, for example, live in Washington or may live in New York City, have excellent access to public transportation, and driving is not an issue for them. I have other patients who live out in the suburbs, and driving is critical for them. I recall one woman who I saw recently, a single working mother who lived in the suburbs. And when I told her that the first seizure because of this first seizure, she would not be able to drive. And she said, Dr. Krumholz, if I can't drive, you may as well cut off my legs, because I won't be able to take my children to school and I won't be able to work. So for this lady, the possibility of a second seizure is a major burden. And so in her case, I think immediate antiepileptic drug therapy would be more warranted. But also one has to consider her risk. If she didn't have an abnormal MRI scan, or if she didn't have an abnormal EEG, or she didn't have an underlying cause for the seizures, her risk would be less. Needless to say, in somebody like that, one might treat her based on her preferences, while if one had someone who was at very low risk, one might not treat them one might not recommend treatment, particularly if they had reasons that they didn't want to be treated. Some people are holistic, they don't want treatment unless they absolutely need it. So I think that, again, combining a patient's personal preferences, educated preferences, with what we know about the risks of recurrences are the way to proceed in this way. And that's one of those reasons that this guideline came out. Neurologists are more sensitive to these issues, but a lot of these people or patients with a first seizure don't present to neurologists. They'll present to an emergency room, they'll present to a primary care physician, and those individuals don't always have access to all this information. But this American Academy of Neurology guideline will be on site, it'll be promoted, and we hope that ultimately people will realize that this is a good resource and will go to this resource when they're confronted with a patient. They can Google it, they can find it fairly easily, and then they can see that there are options to treat some patients, but not necessarily to treat all patients, because I think you're absolutely right. The default is some physicians will treat everybody, and other physicians will say, well, I don't know what to do. I'm not going to treat anybody until they see someone else. These are some answers that we've had from previous literature, but I would say that there are some things that we really don't know. So, for example, I pointed out to you a number of risk factors for seizures. What we don't know whether these factors are additive or they're just related. So if you have two of these factors, are you more than double the risk? Is it how much does the risk increase with each of these factors, which will help you decide whether or not treatment is indicated? We don't know that. We think studies are warranted to assess that. The other thing is that we don't know is how long to treat a patient after a first seizure. Generally, we talk about treating somebody for 2 to 4 years, and if they remain seizure-free, one can then discontinue medication. But here we don't really know that for sure, because this is a new cohort of patients, people with just a single seizure, and we don't know exactly how they're likely to do. My guess is that they have about a 30% chance of a recurrent seizure, but it might be lower after a first seizure, and if they have less risk factors. So studies of that are warranted. And finally, we have a lot of new anti-epileptic drugs. The studies that I'm reporting on and that we've reviewed are based on some of the older drugs. I'm an old timer, so they're sort of my friends. But for a lot of people, there are a lot of new drugs that look even more exciting. And what we don't know is what the side effects of those drugs will be and what the efficacy of those drugs will be in similar situations.